Do you really need your appendix? Hi, it's Dr. Fan here. Let's talk about appendicitis. Appendicitis is the inflammation of the appendix. It is a common surgical problem that occurs to around 1 in 1,000 people every year. It has a slight male predisposition of 1.5 to 1 and is most common in the age groups of 10 to 20-year-olds. Your individual lifetime risk is about 6 to 9%. Appendicitis is caused by the blockage of the appendix lumen by a fecalith, bit of poo, hyperplastic or enlarged lymph nodes, or even tumor. The blockage then causes the appendix to swell and become edematous and inflamed. The inflammation results in the formation of clots in the small vessels of the appendix, typically the veins first, then leads to further congestion, eventually blocking the arterial supply. This lack of blood flow causes ischemia and necrosis of the appendix. If left untreated, they can cause complications. The complications of appendicitis include phlegmon formation, which is a mass of inflammation originating from the appendix and spreading to surrounding areas, abscess formation, which is a progression of the phlegmon, resulting in a ball of liquefied pus encased in surrounding inflammatory tissue, perforation, which is when the appendix ruptures completely and pus leaks out of the appendix. The typical presentation of appendicitis is a migratory pain that starts around the umbilicus and migrates to the right iliac fossa. It is associated with anorexia, nausea, and vomiting, and may also cause a fever. Physical examination signs include McBurney sign, which is pain in the right lower quadrant over McBurney's point, being 1/3 of the distance from the ASIS to the umbilicus, as demonstrated in this diagram. Robsing sign, which is right lower quadrant abdominal pain on palpation of the left lower abdomen. Psoas sign, which is back pain on right hip flexion due to irritation of the psoas muscle. And obturator sign, which is pain on internal rotation of the hip due to irritation of the internal obturator muscle. Investigations for appendicitis include blood tests and imaging. The main thing to assess on blood tests is total white cell count and neutrophil count. With appendicitis, the white cell count will be elevated. A CRP may also be a helpful marker for inflammation to support the diagnosis of appendicitis. Imaging options include ultrasound and CT scans. Ultrasound is generally preferred in younger people due to the avoidance of ionizing radiation present from the use of CT. Ultrasound findings for appendicitis include an appendiceal diameter of greater than 6 millimeters, an appendiceal wall thickness of greater than 3 millimeters, presence of an appendicolith, a non-compressible appendix, and prominent periappendiceal fat. Ultrasound is also useful in finding other pathology such as ovarian cysts and mesenteric adenitis if the appendix is demonstrated to be normal. A CT scan is more accurate in diagnosing appendicitis, with the sensitivity and specificity both of around 99%. It is the preferred method for people aged over 40 given the increased likelihood of cancer being the cause of appendicitis, and allows for early diagnosis and treatment. CT findings include appendix diameter greater than 6 millimeters, an appendiceal wall thickness of greater than 3 millimeters, presence of an appendicolith, appendiceal enhancement, and fat stranding around the appendix. A scoring system for likelihood of appendicitis exists, known as the Alvarado Score. This is a 10-point score based on the findings of anorexia, nausea or vomiting, migratory pain, right lower quadrant tenderness, fever above 37.3 degrees Celsius, white cell count greater than 10,000, and a white cell left shift, which just means increased proportion of neutrophils to total white cells greater than 75%. However, with the availability of imaging, this scoring system has largely been superseded by the use of ultrasound and CT. The treatment of appendicitis is generally operative. Laparoscopic appendicectomy is the preferred approach and is one of the most common operations in the world. This is usually performed at time of diagnosis. However, there are exceptions where a delayed appendicectomy is preferred. This includes the management of appendicitis complications such as appendiceal phlegmons and abscesses, where immediate appendicectomy results in higher complication rates. Such complications may be managed with intravenous antibiotics and the insertion of a percutaneous drain to drain the abscess. First drain the abscess and then come back to perform the appendicectomy once inflammation settles. Appendicitis may also be managed non-operatively with intravenous antibiotics. This is reserved for uncomplicated appendicitis in the absence of an appendicolith. This management, however, has a 30% 1-year recurrence and a 50% 5-year recurrence risk. There are a number of other unexpected findings that may be evident at the time of appendicectomy. Number 1, the appendix may actually be normal. In this case, we need to perform a diagnostic laparoscopy and assess the entire small bowel, cecum, mesenteric lymph nodes, uterus, fallopian tubes, and ovaries to assess for another cause and treat appropriately. In the absence of another surgical problem, the appendix should still be removed to avoid future diagnostic confusion. 2. Pinworms or enterobiasis. Occasionally, worms can be seen in the appendix after removing the appendix. These worms die when out of the bowel environment, but still need additional treatment to eradicate the remaining worms. This involves the prescription of albendazole or mebendazole, both of which are anti-helminth medications, over the course of 2 weeks to eradicate the worms. 3. Appendiceal cancer. This is usually diagnosed after the operation on review of pathology, which is another important reason for having post-operative follow-up. The type of cancers include neuroendocrine tumors, adenocarcinoma, and mucinous tumors. The specific management of each depends on a multitude of factors, but most likely will require another operation for adequate resection. There are a number of specific population groups to consider. 1. Immunocompromised patients. CT abdomen should be done given the diagnostic difficulties. The management is always operative because source control of the infection is essential in immunocompromised patients. 2. Children. Children should be managed similarly to adults. Pediatricians will say that children are not miniature adults, but appendicitis is still appendicitis. 3. Pregnant patients. Consider an MRI if there is still diagnostic confusion after an ultrasound. Operations are the safest around the second trimester, but appendicitis can be life-threatening to both the mother and baby, and an operation should not be avoided due to pregnancy status. During the operation, opt for lower insufflation pressure of 12 mm of mercury to reduce intra-abdominal pressure. If the appendix appears normal, still remove the appendix, because even if it appears macroscopically normal, it can still be microscopically abnormal. Thank you for watching. If you like this video, please like, subscribe, share, and comment for more videos.